The views and opinions expressed in this presentation reflect those of the speakers and do not necessarily reflect those of the United States Department of Veterans Affairs. That's the first time I've ever had to read a disclosure like this on the podcast, and it makes me feel very important right
Very
now.
official.
Like, I have made it to where I have a big head honcho guest who is like involved in the government now. Like, this is a first, Kayla, so I'm really
Government
excited.
employee.
Hello, OncoPT, and welcome to this episode of the OncoPT podcast. I am so thrilled today to have a very important guest on the OncoPT podcast to talk all about neuropathy, specifically from a neuro, or as I have learned today, a new phrase, NorthoPT. So the neuro-ortho lens on neuropathy, and then how she is really taking that and applying this to some of her more medically complex patients, including some of her patients with cancer. So I'm so thrilled to welcome Dr. Kayla Gomes to the OncoPT podcast. Kayla, welcome.
Thank you. So excited to be here. Thanks for letting a neuro or Northo PT invade in the OncoPT space.
Oh, we're here for it. We're here for it. Would you mind just telling us a little bit about yourself, how you got started in PT, and maybe even a little like what drew you to the neuro side of things?
Sure. So I went to PT school thinking I was going to be a hand therapist, actually.
Oh.
I know, it's very random. I ended up falling in love with the neuro content, and I was a PCA for a gentleman who had an incomplete spinal cord injury and hired PT students from our PT school, and he was really into working out super hard. So I got some of that high intensity very early on in my career before I even knew. So when I left PT school, I was interested in pursuing this interest in neuro. I applied and interviewed at, I think, 3 neuro residencies, and I didn't get into any of them. And at the time, it was really devastating because that was the first time academically I hadn't been successful at something. So I took some time to be sad about it and reflect because, you know, I was very green. I had great clinical placements, but none of them were really in neuro. So in hindsight, I don't think I would have gotten the most out of residency anyway, and some of my interviews weren't exactly strong. So I was like, okay, what do I do? And so then I applied to jobs all up and down the East Coast, and I was looking for a job that not only had mentorship, but I could see everything, not just neuro, but everything else, just to really make sure I liked it. And I was very lucky at my first job. I had great mentorship, great coworkers, and I got to see everything. I saw neuro, I saw ortho, and I saw a lot of medically complex patients, which is something that I really loved. They even had an oncology program there. My mentor handed me like the STAR, like level 1 packet and was like, here you go. You seem to be interested in this. So that's how I was introduced to oncology. So then eventually I did get my NCS during COVID. All my hobbies were canceled. I'm like, I'm going to do this now. So I ended up getting the NCS. And at that last job, I saw mostly central sort of neuro. So MS, stroke, concussion, brain injury. But now I'm at the VA, and that's more peripheral neuro disorders. So I see neuropathy, falls, balance, vestibular. But, you know, from my first job to now, I really like having a varied caseload. So I really do see everything. I see neuro, ortho, this medically complex population. I like seeing it all, and I didn't coin the term Northo PT, but I do like it, and I will use that to describe myself in my practice today.
I like that.
Yeah.
Like I said, I heard it first from Kayla literally today, so in my mind, like she invented the phrase, so that's what we're going with.
Yeah.
When you were first starting to work with this patient population, let's kind of shift more into like your current work, which is more of the peripheral neuro issues here. One of the things that you and I were talking about off air is like, neuropathy is kind of hard. Like, it's kind of hard to treat.
Yeah,
it's kind
totally.
of frustrating. Can we establish for the audience who's maybe like a little newer, they understand, they've heard the word neuropathy before, but can we establish a definition of what we're working with here?
Absolutely. I get patients all the time who come in and say, the doctor says I have neuropathy. What is that? And I have to pause because I'm like, what's neuropathy or what's your neuropathy?
Right. Oh.
Because neuropathy is an umbrella term. It just means like a disease of the nervous system. And if we're talking about peripheral neuropathy, obviously it's a disease of the peripheral nervous system. But like, a Guillain-Barré is considered a peripheral neuropathy. That's typically not what patients are coming in to see me for. They're typically seeing me for this length-dependent sensor motor neuropathy, usually in my population caused by diabetes or chemical exposures from things like chemotherapy or with my VA population, Agent Orange. So that's a very unique exposure that can cause neuropathies. Other things that can cause neuropathy, alcohol use is a big one that I see in my population as well. And then there's just this idiopathic neuropathy that becomes more common as people age. That can be very challenging for people to accept because they'll say, I did everything right. I don't have diabetes. I don't drink. What the heck is going on here? So just trying to manage that is somewhat different. And then do you want to talk about like the evaluation, the treatment, or you want to talk more about like bringing it to oncology again?
Yeah.
Different treatments can cause various levels of neuropathy or different types of neuropathy. Yeah.
Yes.
Yeah.
That's one of the things I'm reflecting actually now. I had a patient previously who was a veteran of the Vietnam War, and his cancer was actually caused by Agent Orange. And I didn't even think to go that way in this conversation today, but it just brings back like memories of, oh my God, like I completely forgot about that patient.
Yeah. So, a lot of prostate cancer.
That is so interesting. See, my patient had, what did he have?
Cancers of all types, but a lot of prostate cancer.
Yeah, he had a head and neck cancer. And he developed it like really early on.
Yep.
That is interesting. We might have to talk more about this off air because I'm really,
will do. Yeah.
There's some gears turning already, which is fun.
Yeah.
Let's kind of take it back a little bit to more of like establishing our baseline of neuropathy. So we've talked about, definitely like this chemical exposure. Now in oncology, a lot of times it tends to be the, chemotherapies. We're seeing some immunotherapies that are even contributing here. But one of the things we really haven't talked about on the OncoPT podcast yet is that we know neuropathy is a thing. We know that CIPN, definitely a concern, but we don't really talk about the fact that this may not be our patient's first rodeo with neuropathy. Right. And I think we need to talk a little about that.
Right. So, because a patient could have diabetes and dealing with neuropathy. A lot of the time that can be progressive, especially if they don't have good control of their diabetes. And then you're adding a secondary neuropathy on top of it.
Yeah.
Which can be very challenging. So in that sort of situation, what I would do is if you have the ability to evaluate your patient prior to their cancer treatments, do it and do a pretty extensive sensory screen and evaluation. What I typically do is at least monofilament and vibration testing.
Yeah.
And that 5.03 monofilament for protective sensation. You can get real nitty gritty into like sharp dull if you want. And also foot and ankle strength. And then looking at some of the more functional things like single leg balance and then moving way into things like doing a DGI or an FGA so that you can track change. That's going to be really important with those populations that might have a pre-existing neuropathy from another disease or chemical process who might be going through another chemical process on top of it.
So when you have a patient coming in and like let's say you've got a chart in front of you, right? Like you've got the chart from the physician, but you don't have a lot more information than that. You know that they've got neuropathy. You don't exactly know what it's caused by, if this is a diabetic neuropathy, if this is a CIPN, is this a both situation? When that patient comes in the door, how are you starting your evaluation with that patient?
A really thorough subjective history.
Okay.
Because neuropathy can cause a lot of things, right? And I guess I should have mentioned this in the beginning with what's a neuropathy. It's a disease of the nervous system, and your symptoms are going to be dependent on which nerves are affected.
Mm-hmm.
So if we're talking more like small fiber neuropathy, they could have a lot of pain, paresthesias. They could lose temp, manage. Oh my God, not management of temperature, sensation of temperature.
Yeah.
You might see with some of those small fiber neuropathies, even autonomic neuropathies too. So they could have some orthostatic hypotension. If we go more to large fiber, you're going to see more like painless paresthesias. They might not feel anything, even like deep pressure. They might start losing vibration, proprioception, and that's where you start to see changes in skin, and even some loss of deep tendon reflexes and weakness of the foot and ankle. So, kind of lost my train of thought. Where was that question going? I'm just going.
So the first question I asked was like, how do you start your evaluation with these patients? And you said a very thorough subjective answer. So then we took it back to small versus large fibers.
Right.
And I have a follow-up after you finish your thought, because you brought up something I'm really excited about.
So, depending on what nerves are affected, you can have all these different types of symptoms.
Right.
The two biggest complaints are pain and imbalance. Those are the big two that I deal with. And typically, patients are referred to me because they're falling.
Yep. That sounds familiar.
Because they're falling. I would love, and this can go with many diagnoses, not just neuropathy or people who are going to go through cancer treatments. I would love if my patients got to me earlier.
Because I feel that so deeply.
Because if they're already falling, it's challenging, right?
Yeah.
So where do you, okay, I have neuropathy. Do you feel anything? Do you have numbness or tingling in your feet? Is there any pain associated with that? Because a lot of my patients, by the time they get to me, they don't even feel their feet at all.
Yeah.
So then I start asking questions about their inner ears. Specifically, like, do you have any history of lightheadedness, dizziness, vertigo, any history of hearing loss or ear ringing? Because I'm thinking of the big three inputs to balance: vision, vestibular, and somatosensory. So if I know we're already lacking some somatosensory input, I'm already thinking ahead to, okay, what can I help my patients use to kind of retrain their balance system? And I got to tell you, with my patient population, they're older. They have exposure, like occupational exposures, gunfire, blasts.
Right.
That can cause vestibular hypofunction. So now we're not just dealing with a neuropathy in their feet, we're dealing with a vestibular hypofunction. So I asked them, you have some numbness and tingling in your feet, you have some pain in your feet, like, okay, ever get dizzy and ever get vertigo? Sometimes they don't know. So then I ask questions such as, when you're in the shower and you close your eyes, what happens? And a lot of the times they'll say, I feel like I'm going to fall over. Or I grab the wall, or I grab a grab bar. That sets off an alarm bell in the back of my head, like, okay, we're probably dealing with some vestibular stuff, right? Any orthopedic problems, before the neuropathy or after? You were talking about before patients who have other neuropathies or like pre-morbid comorbidities. think of a lumbar radiculopathy. That's technically a neuropathy, right? So they might come to me and say, yeah, I've had sciatica forever that goes all the way down to my foot, but now I'm starting to feel like numbness and tingling in both of my feet. Is that from my back? Probably not. Right? We probably have two things going on at once.
Right.
Right. So I guess with my subjective, it's, why are you falling? What is your current sensation? Trying to figure out what their vestibular system and their visual system might look like. And then taking it to my exam from there.
I'm really excited. A couple different things. So I want to take it back actually a little bit. I'm so thrilled that when we were initially talking about small fiber issues, right? You mentioned, of course, like we've got some sensory, potentially like motor issues here.
Right.
But what you also mentioned is autonomic dysfunction.
Yeah.
And Kayla, I kid you not, it took me like 2 years, maybe 3 years into my practice before I genuinely understood that neuropathy is not just a sensory motor issue. Like it can also be autonomic, and it makes me giggle now because I'm like, oh my God, like I knew so little back then, but now I'm also like, what was I missing? Like what clues were I missing?
Yeah.
In my patient who like had definite neuropathy, and I just did not put it together that their autonomic issues were related to the neuropathy.
Right, especially with some of these systemic causes of neuropathy. I say to my students, and I say this tongue in cheek, but I'm like, the vestibular cochlear nerve, it's a nerve, right? So if we're thinking of diabetes and how it can affect the nerves in the hands and the feet, why not the inner ear? And it does. If you look at the research for diabetics, they have more vestibular issues than age-matched and, comorbidity-matched controls. And I had this conversation with Scott Capozza at CSM because at the time I was doing a ton of reading on like different types of neuropathies, or not neuropathies, different types of chemotherapy and how they can cause neuropathy. And I must have had a patient with cancer at that point. That's why I was looking into it. And they kept talking about the platinum agents and how some of those are ototoxic. But they didn't talk about any other chemotherapy. And I read one paper that even said, oh, yeah, it can cause neuropathy. It can cause CIPN, like the sensor motor thing. But it's sparing to the vestibular cochlear nerve, to the inner ear system. And I'm like, how is that possible?
Yeah, how?
I don't think, and I did a ton of reading before I came here today because I was like, did I imagine that wrong? There really isn't much out there looking at anything but these platinum agents in the ototoxicity, like the hearing loss and some of the vestibular loss you can have with those agents. Whoever's listening out there who does a lot of research regarding chemotherapy agents, you should look into that, like how different types of chemotherapy may result in vestibular loss. We already have the research that it shows poor balance, but everyone just talks about like the sensor motor piece. They can't feel their feet.
Right.
They lose that proprioception. Well, what about their inner ear? That's just my little soapbox that if I had more time, I would research into.
No, totally. And that's, first of all, vestibular system. I mean, we're already talking about patients having falls and balance problems and being a fall risk. Like this is already an issue, even if we're just talking about like the sensory motor side of things. But then you throw in that and then thinking about, gosh, chemotherapy has so many different side effects anyways.
Yes.
And I think a lot of times, at least in my world, Kayla, and I'm curious if you have this perception or perspective too, we kind of throw a lot of side effects on chemotherapy of like, oh, it's just chemotherapy, like, wow, whatever, without really considering this may actually be a neuropathy issue. Thinking about, some chemotherapies cause GI distress and GI issues. Yeah, totally. The chemotherapy definitely affecting those mucosal, linings, et cetera, et cetera. But some of those, it goes deeper than just mucosal irritation, right?
It's
like
the
there's
autonomic
other
nervous
things.
System. Yeah.
Yeah. Oh man.
I agree.
Oh man. Okay, before I get too sidetracked again, because it makes me so excited that we're talking about autonomic stuff because I missed that so badly for like several years of my practice
I
initially.
feel like it's not taught as well in schools.
Yeah.
Yeah, I think there's more of it now because of COVID.
That's a good point. That's a
And
really good
if
point.
you've done a lot of study into concussion, you'll learn a lot more about the autonomic nervous system. But speaking for myself, I don't think I got a lot of autonomic nervous system consideration in PT school.
That does make me feel like 5% better. If you didn't and you're like a neuro person, then I feel a little
Yeah.
better. And it's interesting because we have some literature about CIPN and we're getting more every year.
Yeah.
But a lot of what informs our practice in a lot of situations is really like diabetic neuropathy. And that's
Yes,
definitely like there's a
exactly.
lot of
Yeah.
ties.
Yeah.
But we also can't forget like there are also some differences like we should probably be aware of with all of this.
Yeah. Yep. Exactly.
Oh man. Okay, I'm gonna reel it back in. So we're going back to our evaluation now. You have taken a very extensive subjective history. You've asked a ton of questions on what are they experiencing, how are they experiencing it, kind of like the when, what are the circumstances in which they're experiencing that. So
Right.
you've got this subjective information. What are you then going to do in your evaluation of this patient?
I'll do a sensory exam. If you look at the diabetic neuropathy literature, I read somewhere that the best sensitivity and specificity with all the tests is if you do monofilament and vibration combined. So that's typically what I do. It really doesn't take a lot of time. And I'll get on my soapbox for a second.
Yes,
For your
please.
patients with neuropathy, especially diabetic neuropathy, you need to check their feet. You need to check their skin. So if you're doing a sensory exam anyway, you should be taking off their shoes and their socks.
Right.
But I can't tell you the number of times I have found wounds, splinters, and I use that sensory exam as an immediate educational moment. When I show them the monofilament and I say, let me know if you feel this at the bottom of your feet, and if you can, where. If they don't feel any of that, I explain this little fishing line looking thing is called protective sensation, right? So it's looking at if you have a small rock in your shoe or a bunch in your sock or your shoe is bothering you, you'd be able to feel it. But you don't have that sensation. So then my next question is, do you check your skin every day? Most of the time they say, no. And I say, you're going to start. It's going to be something like brushing your teeth. You're going to do it every day. And if they lack the range of motion or strength to do that, I'm very lucky I work at the VA. I can order equipment that I think is medically justified. I immediately order them an extendable mirror to check the bottom of their feet every day.
Very nice.
So, I also am the amputee PT person at the VA. And for patients who might not really get it or want to know more, I say, you know what, this is really important because if you got a cut or a wound, you might not be able to feel it. And the consequences of that can be really extensive. Like we're talking infections, we're talking amputations. And no one wants to think about that, right?
Right. Right.
So I'll do a sensory exam. I'll check their strength up and down the chain. So I'll check toe strength, just distally first to see what their strength is doing. Dorsiflexion, inversion, eversion, knee flexion, extension, hip, all planes, because that might also affect their ankle and hip and stepping reactions later. And then I personally do a vestibular ocular screen on all my neuropathy patients, every single one, because of that three systems thing, right? If someone has neuropathy, diabetic, chemotherapy, Agent Orange, and realistically, I don't think I'm going to be able to improve that somatosensory system. What are we going to rely on instead? So if their vestibular system, they have a hypofunction on one side or both sides, or they have dizziness or vertigo that's chronic or acute, my prognosis is going to be a little more guarded than those who have that intact. That's just the reality of it. And for those who are lacking that somatosensation and that vestibular input and that visual input sometimes because of diabetic retinopathies or cataracts or whatever it is, if you're missing 2 out of the 3 or 3 out of the 3 of those inputs, I start thinking about more compensatory strategies. Grab bars in the shower chairs and shower benches. Again, I'm very fortunate at the VA. That's something that I can just dispense if I think it's medically justified. Canes, walkers, not because they have a weakness, but because their brain just needs something to help them orient in space. That would come out in the subjective history too, if they're wall walkers or furniture walkers.
Yep.
Yeah.
Man.
And then I try to do some sort of functional outcome measure, tying it to what they have the most trouble with. I like the DGI and the FGA. I really like the mini best test, but it takes a little bit longer. Tug 5 times sit to stand if they came late to their appointment and we don't have enough time, if I'm being totally honest.
Right. I'm here for it.
Yeah. And then we go from there. That's what my evaluation typically looks like.
I like that. So kind of zooming in on some stuff. We had previously mentioned this off air, but I want to bring it back. So if you're working with a patient, what are some potential signs of something else is wrong here? Something is not right as far as like red flags, even like some orange, like I've heard them like orange yellow flags, right? Yeah. So what are some of those that you might be looking for in this patient population with neuropathy?
Yeah. And I work at the VA where it is true direct access. So, or they'll call up their PCP, be like, I'm having trouble walking. I want to see PT. And they don't really have any diagnostics. Your typical neuro red flags are important to remember. Going back to the oncology population with some of these brain mets or spine mets, right? Like if there is a sudden change in speech, swallowing, vision, bowel and bladder control, numbness or tingling in the face, perhaps like unilateral numbness or tingling and like gross weakness, right? Like these more strokey central signs. And sometimes I get people who are really panicked looking at somebody's gait and they call it an ataxia. That's another pet peeve of mine. Everyone who has, gait deviations is an ataxia. I'm like, that's not what ataxia is. But asking the question, like, okay, you have this wide base of support, you're holding onto walls, you feel really imbalanced. Has this been going on for a long time? Or you woke up with this 10 out of 10 headache, you're really dizzy, and now you can't walk unassisted. That's when we start thinking about like a HINTS exam, right? To rule out like a posterior circulation stroke.
Yeah.
Less red flaggy things, reticulopathies. Like, is it just unilateral? Because you can see unilateral numbness or tingling or unilateral myotomal weakness in those situations. But with a lot of these signs, you can rule it in or out with your subjective history or with your exam, right? If you're checking reflexes and they're hyperreflexive instead of hyporeflexive or absent, that's a central sign. That's not a sign of neuropathy.
I love how it comes back to basics. Like, it really does.
It really does. Like, when I came to the VA and I started, 20 patients of neuropathy, and I'm like, oh my God, like, I just know stroke and MS. What do I do?
Right.
It really comes down to basics.
Yeah.
It really does. Like, your basic clinical skills and exam.
Did you, in PT school, did you ever hear the phrase of like, if you hear hooves, it's a horse? Or like, it's not a zebra?
Yes.
Okay. I feel like, especially when I was first
I have mixed
practicing,
feelings about this. I tweeted about this at one point.
I think as a new grad and as someone new to oncology, everything was a zebra that I was hearing. Like every time I heard
Sure.
hooves, it was a zebra.
Yeah.
It was actually a horse most of the time.
Mm-hmm.
But every once in a while,
Right.
it was a zebra. Like I had one patient who I had seen her previously, so I knew what her kind of function was.
Mm-hmm.
She came back about 6 months later and she was totally different. So previously, she was ambulatory, independent in
Yep.
all of her stuff, walking around like we were good. 6 months or whatever later, she comes in, she is pushed in to the clinic in a wheelchair by one of her children. And I was like, oh my God, what is this?
What happened?
And like, right? And so previously, this is one of my very like memorable zebra situations. But again, going back to what Kayla's saying about, it really does come down to these basics. Like, what are these neurosigns that we're looking for that potentially indicate a problem? And I should have listened to my gut because, yes, this was one of those zebra situations. Imaging had actually ruled out metastatic disease. Like, we were very much under the impression that it was not the case, but she had this radiculopathy. I was like, what is going on? And like, I did every back test, like lumbar spine test in the book I could think of. I was like, oh my God, I can't figure it out. Da, 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 da. And so like, long story short, eventually I gave up and I was like, radiation oncologist, I'm so sorry.
It's
Like I don't
not
know what's going
responding.
on.
Yeah.
We need to do more imaging. And they're like, okay. Sure enough, the first round of
Scary.
imaging had missed it, but there were neurosigns the whole way that I was just like, no, it can't possibly be it.
Really?
It can't possibly be it. But again, like,
Do you feel comfortable
had-
sharing what those were?
yeah,
What those neuroscience
so
were?
absolutely. So for this patient, this was a couple years, so I'm probably forgetting some details. One of the biggest red flags when it comes to pain in oncology is unrelenting pain.
Yeah.
Worse at night. I mean, like
Yeah.
all of those, you know, like like malignant related pain things. She
Right.
fit all of that. Nothing changed it positioning wise. Gosh, I'm trying to think what else she had. The pain was just so extreme. That's what I was sticking out the most. Let's see. She had radiating pain down her back, into her butt, and then a little bit into her thigh. She did have weakness, like in that area. That was new. It was unilateral. That was, you know, that was a new development. I don't think she actually had any sensory changes.
Oh, interesting. I guess it
However,
would depend where in the spinal cord it was.
this was
yeah.
also like 3 years ago, so she could
Yeah.
have, and I just forgot about it. But again, just going back to like, there were basic signs, there were basic red flags that I was like, nah, like can't possibly it. You know, like they already said that it wasn't the case. So, yeah, it's usually not a zebra, but every once in a while it is a zebra. And those basics would have told me from the beginning it was a zebra, and I should have just listened to my gut.
Well, thanks for sharing that because like these are
Yeah.
the things that we learn from, you know. I had a patient who has metastatic cancer. Name a bone, there's a met there.
It's there, yeah.
It's
Ugh.
tough, except for the cervical spine and the skull. He woke
that's
up one
good.
day, horrific dizziness. And they were like, this is it. It's in his brain, it's in his neck. He had BPPV.
Oh my God, are you
But like
serious?
if you talk to the patient, it's like, when do you get dizzy? When I get out of bed. I feel like I'm gonna fall. I feel like I turn really fast and I'm gonna fall over. How long does it last? Oh, a minute. That's not like your typical, like a positional vertigo like that isn't. But because he had cancer and he had
Right.
these metastatic mets, everyone freaked out.
Right.
Yeah. And then once we realized it was not we, once they, the referring people, realized that it was BPPV, everyone was freaked out to treat him because of his bone mets. You know, and positioning him, right? Because he had some pain in
Right.
his back. So it's like, how are we going to change our repositioning maneuvers to account for that? Yeah, it's hard.
Do you mind sharing like what you ended up doing to be able to perform those repositioning maneuvers with this patient? Did you end up doing that with this patient?
So he had some neck discomfort, but no mets. It was just like a tight muscle pain because his posture was not very good.
Makes sense.
With sacral, lumbar, and thoracic mets, we were able to do the epley, but with some position changes and some
Okay.
support with a lot of pillows.
That's kind of what I was thinking. Pillows. Yeah.
Yeah, I didn't get him into like the full 30-degree cervical extension because it got into his T-spine a little bit. I
Okay.
just kind of tipped his trunk back, like put some pillows underneath the trunk and got it that
Yeah.
way.
Oh my
That's what I did.
God. Love that.
Yeah.
See? Oh my gosh. See, like you said, Kayla, this is how we learn about these things. Like,
Yeah.
this is where the real learning happens. I love that.
Yeah, exactly.
Okay, so we've done our evaluation, subjective, objective. Now it's time to actually get into a little bit of treatment. Now I
Yeah.
know it depends on the
Always.
patient. But
Always.
what are maybe some things that we can get started with for the person who's experiencing neuropathy? You know, maybe we've even got a little bit of diabetic neuropathy in there on top of some CIPN. Like, what do you think we should do here?
So, if they have intact vision and vestibular input, I would say let's kind of build that up a little bit. Some of that more substitution type thinking in the
Yeah.
vestibular rehab world. That said, if they still have some somatosensation, right? But it's proximal to the ankle, you can still work on things like ankle, hip, and stepping reactions. Depending on how bad their balance is, I start with weight shifting. I start with a lot of stepping forward, alternating forward, backwards, and side to side. Um, yeah, it's so hard because it really does depend. Something that a lot of people don't know about. And, I was saying like, okay, I don't expect to improve their somatosensation. I don't expect to increase that somatosensation. That's not exactly true. And not sponsored by either of these companies, but I'll talk about them.
Love it.
In my VA, we call them sensory aids. So there's two types. Walkisins. Are you familiar with a walkisin? Okay. A walkisin is a device that I say to patients, it looks like a house arrest anklet. It looks like a house arrest anklet. Goes around the ankle.
Okay.
And then there's a little wire, essentially, that goes to a sensor that they put at the bottom of their shoe. Kind of looks like an AFO, but it's not. It's very flexible. So when they weight shift to their toes or the front of their foot, it will transmit that to the anklet, which has vibration on it. So what you're essentially doing is if they have like a plantar sensation loss, you are replacing that and moving it proximally to a vibratory sense. So if they shift forward, it vibrates the front of the tibia. If they shift backwards, the posterior part of the tibia. Medial, lateral, you get it. So, we can use something like that to retrain their brain to attend to a more proximal part of their leg with the vibratory sense to help them know where they are in space. That's a very specific type of patient, right? Because they can only really have plantar sensation loss. If they have sensation loss above mid tibia, it might not be efficacious for them. And at least in my VA, they have to go through a whole traditional balance PT plan of care before we trial something like that because they are more expensive.
Okay.
The other option, not sponsored, but I love this company and I love this product, Naboso. Do you know what those are?
I feel like I've heard of it, but I don't have a lot of experience with it.
They're called a proprioceptive insole, and it's just like this thinner than a Dr. Scholl's insert that you put into the shoe, and it has this harder plastic textured surface on it that looks like little pyramids. So what it's doing is it's increasing the amount of input that people have at the bottom of their feet. And they have two different levels. One is blue, I think it's called active. One is gray, it's called their neuro insole. Blue is less aggressive than the gray.
Okay.
So going back to my evaluation, if someone has protective sensation intact, I might consider using a Naboso just to up that somatosensation input a little bit. right?
Right?
I don't put it in someone's shoe if they don't have protective sensation. I don't think
Totally.
that's a safe thing to do.
Right.
But for some people, it can be really great.
Oh my
In my
God.
experience, I think it works better in people with centrally mediated proprioceptive issues. We use
Okay.
it all the time with patients with MS where their peripheral nervous system was intact. It's just that the signal and what they were interpreting centrally wasn't quite correct.
Yeah.
So if you gave them a little bit more of that peripheral input, it would be better. Peripheral neuropathies, you got to try it with people.
Yeah.
So with that, I would do like a Romberg and all those functional tests, TUG, FGA, DGI, whatever, slip those in their shoes and then retest them and see if there's improvement.
Oh my God.
Yeah, and it's great.
Oh my
And
God.
we haven't talked about pain
Yeah.
quite so much with neuropathy. Neuropathy is hard to treat. I think pain is the hardest thing to treat with neuropathy.
Yeah.
Sometimes with the Nobosos, there's improved pain. I've had the most luck with people with CIPN actually who aren't necessarily falling, but they have that burning sensation, or it feels like they're walking on marbles, or it feels like they're walking on sand and it's really unpleasant.
Yeah.
I have tried the Noboso with them, and I had a guy whose pain was like 7 or 8 out of 10 all the time, and it went down to like 1 or 2 out of 10.
Oh my God.
It was like life changing for him.
Oh my God.
But again, you have to try it because, like, for that person, it was great. But I tried it again with another patient, and it was too much for them, and it increased their pain.
Yeah.
So, you know, the Noboso are financially a little more accessible to people. They're like $50 or $70, depending what type you get.
Yeah.
Moccasins, oh, I don't know. For the VA pricing, it's like $4,500. And I
Oh.
think a
Ooh.
vendor could
Okay.
work with you on the outside and like
Yeah.
try to get it covered by insurance, but I think it's typically something that's out of pocket for the patient. So these are
Yeah.
things you got to consider
Right.
before introducing them to people or the idea to people.
Yeah.
And they can both be used with AFOs. We haven't even talked about AFOs in people who have like some of
Oh
that
my
motor
God.
weakness.
Oh my God. Like foot drop,
Yeah.
huge issue in some of our
Yeah.
patients. Yeah.
Yeah.
Ooh. Yes. Oh my God. Yes.
Yeah. So sometimes I'll try that. I'll try those sensory aids to increase that somatosensory input too.
I'm really glad you brought up the foot drop because that's something, again, I feel like when I first started learning about CIPN as a very like naive student, wide-eyed and bushy-tailed, I was like,
Right.
oh, neuropathy, numbness and tingling. And then I didn't really understand about the motor side of things.
Yeah.
But man, that foot drop is
Brutal.
vicious. And
Yeah.
I haven't treated a whole lot of them. I've had a really, really hard time with foot drop with neuropathy. And a lot of times we end up like, I don't know that I've been able to work with the patient to get that function back. Like we usually end up really moving into like an AFO and like other compensatory strategies because man, I am just like I'm not making progress with that.
I think it totally depends on how much strength they have. You know, if someone has some tripping and they have like a 3+ or 4 out of 5, all right, let's try some ankle strengthening exercises and see how they fare. But I agree with you. If they're less than 3+ and they're tripping all the time, you're going to have to do something more compensatory. And
Yeah.
with that, with AFOs and that sensation loss that's usually accompanied with it, you have to get something more customized too, so that it's in full contact with their skin and they're not dealing with any skin breakdown issues that they might not be aware of.
Yeah.
Yeah.
Yeah, I'm just thinking of our brutal summer that we had here and just like all the sweat in the shoe and oh my God. All the rubbing and the friction, ripe opportunity for blisters and so much more with this patient population.
Very much so. And patients are so embarrassed to show me their feet, and I'm just like, your hands are more gross. Really. Like, Like it's fine. I've seen it all. I've seen everything.
You've seen
Yeah,
a lot of feet, like feet,
a
and I think
lot.
I tell my patients the same thing. I'm like, I'm not going to see anything on your foot that I haven't seen before, and I can
Right.
guarantee I've seen grosser feet than what you're going to show me. So,
Right. Exactly. Yeah.
what?
And
Yeah,
talking
go ahead.
about one more thing with pain.
Mm-hmm.
I told you I went to a really great course at CSM by Dr. Katie Schmidt, and she mentioned a
Yes.
manual therapy technique, and she had pulled it from like the diabetic neuropathy literature
Mm-hmm.
that was taking, little bits and pieces from like Thai foot massage and joint mobilizations and trigger point. And it's not something that we do the patient, something we have the patients do to themselves.
Yes.
And I tried it with one gentleman, and he would get relief after doing it for about 2 to 3 hours, but then it would come
Mm-hmm.
back. And so he was like,
Yep.
I'm not really into massaging my feet every 2 to 3 hours.
Ah.
And then I tried the Nebosos, and his pain went down by half. I'm like, well, I should have just done that
Well,
to begin
that's
with.
what worked for that patient, right?
Yeah. Yeah. So I feel like I need to mention like that manual therapy technique too. Because that course with Dr. Schmidt was just fantastic.
Can I tell you a secret?
Of course.
I interviewed her last week.
Perfect.
And she like step by step went through it, that technique. So like
Yeah.
listeners, if you're
Perfect.
listening to this now, you're gonna get it. You're gonna get it very
And
soon.
it's on
But
her
one of the
website.
things, yes, that's the thing that
Yeah.
she talked about is like I've got it on YouTube. Maybe, yeah, I think she has it on
Yeah.
YouTube or it's coming to YouTube. But one of the things that she mentioned that I think just as a principle, I need to be applying more, like more of that repetition, intensity over time that like a lot of times we see with neuro rehab
Yeah.
is that you've got to like I think that's one of my big problems is if I find an intervention like I don't necessarily do it. I do it from
Over
an
and over and
ortho
over
and not
again.
like a neuro perspective. And that's one of the
Yeah.
things that Katie talked about is like you have to commit to doing this
Yeah.
regularly if we're going to and like how structured it is. And I do think I tend to be more on the ortho side of like a few sets of 10 and we'll
Yeah.
be fine or whatever. It's like,
Yeah.
probably should actually be a little more considerate of like the
Yeah.
neuro principles of rehab.
And I was talking about like some of the more somatosensory balance training with like weight
Right.
shifting and stepping and those sorts of things.
Yeah.
Use the rating of perceived stability scale. Do you know what that is? It's
No.
like the new thing.
No, I have
It's just like an
not.
RPE from 1 to 10. 1 being like, I could stand here all day. 10 being like, if I don't grab onto a wall right now, I'm going to fall over. And the recommendation is with your balance exercises, it needs to be at least a 6 out of 10, meaning like they feel like they're about to fall over.
Okay.
So it needs to
I
be
need
that
to be doing that.
intense. And yes, with the repetitions, because we're trying to
Right.
improve neural circuits, right?
Right.
And if I'm introducing vestibular training with these patients, like say they have a hypofunction on one side and I want to get that a little bit more responsive, you know, look at the CPG. It's saying have the patients do it 12 minutes a day if it's acute, 20 minutes a day if it's chronic. Okay, all my patients are chronic. And I say to them, I'm like, if I tell you to do this 20 minutes a day, your neck's going to hurt and you're never going to come back. So you got to tell them break it up.
Facts.
You got to break it up throughout the day. I start my patients at 3 times a day with these vestibular type exercises, more or less somatosensory 1 to 2 times a day. But I start vestibular stuff at least 3 times a day. And then if they are compliant with that, then I'm like, great, do more. That's your reward.
I
Do
like
more
that.
of it. Because if I tell them, like, do it X number of times to get to that 20 minutes, they're like, I'm never
Right.
going to do that. Like, let's
Right.
start small.
I'll get to like 10 on a good day kind of deal.
Right.
Yeah, I'll get boom. I have homework from this episode, y'all, which is like first of all, I need to get that rate of perceived stability cuz that sounds like a bomb.
Yep. The
tool.
RPS.
Yep.
And you can print it out. It's beautiful. I have it laminated.
Perfect.
Yeah.
See, that's what I need. That's what I need to get for the clinic. And then you also mentioned the CPG as far as like, again, like look at what the research is showing us as far
Yeah.
as dosing wise. What do we need to actually be doing with these patients? Love it. Love it. Kayla, where can people continue to learn from you and follow up and maybe even like follow you on social media?
My Twitter, oh my God, I have to double check. I think it is NU as in Northeastern University _ DPT. I'm on Twitter a lot. I'm also on LinkedIn. You could email me at kaylagomespt@gmail.com.
Perfect.
Any of those. I like to chit chat about these things. I'm a big nerd. And I would love, truly, I was like, okay, I'm a nerd and I wanted to be prepared. So I'm like looking up articles before this interview. And I'm like, oh my God, what if someone knows more about like chemotherapy and vestibulopathy than I do? Please tell me. Like, if you're like, Kayla, yeah, platinum agents, but also like these chemotherapy agents have now shown all this. Please tell me. You know, there's only so much we can all read. So I'd love to know.
Oh my gosh, for real, right?
Yeah.
Yeah. Oh my God, Kayla, thank you so much for coming on the podcast. This is...
Of course. Thanks for having me.
So, y'all, I tell you, like, the first time I met Kayla, I think I may have, like, followed you or seen you afar on Twitter
social media
before this, but I met Kayla at the 2021.
Yep.
Is that right? That feels...
Yeah.
1,000
Specialty
years
cert.
ago. Nope, it was 22. It was 22 because 21 was virtual.
Oh, and they were celebrating the 2021 kids. Yes.
Yes.
Us.
So
kids.
we met in like the children. Like we are the children.
The newly certified PTs at the time. Yeah.
Yes.
That was us.
So 2022, we are at the CSM like award pin, what have you, ceremony for newly certified specialists. And neuro, alphabetically, starts with an N, and oncology starts with an O. So they're right next to each other. Mm-hmm. And in the very back row of this one section, it was Jen Bernstein, Alexandra Hill, and me. And we were all in this back row, and we were giggling like little children. And Kayla was sitting in front of us. And
I'm like, I love these people.
You made a joke, first of all, and then we just like Twitter, like back there. And then basically Kayla was then nominated as an honorary OncoPT. So that's now she's part of the
I'm honored.
OncoPT coalition.
Noronco. I don't know.
Like that. Mm-hmm. I like that a lot. But yeah, Kayla is a wealth of information to follow on Twitter. She's probably one of my favorite accounts to follow on Twitter because she's always dropping... Girl, like you always have just this, like these nuggets to take from. And I'm like, oh my God, I need to be writing this down. Like, I don't even know how many of your tweets I've saved and bookmarked. I'm like, oh, like I need to come back to that. Like, oh shit, I need to learn that too.
I feel the same way about you. Great.
Now I'm a NorncoPT. I'm an honorary NorncoPT.
Yeah, there you go.
Oh my God, Kayla, thank you so much. This was such a wonderful, very informative interview. And like I said, we've got a little more CIPN content coming up on the OncoPT podcast. Stay tuned. You don't get it just yet, but you will very shortly. So again, Kayla, thank you so, so much. I really appreciate it.
Thank you.